Welcome to Overcoming Physician Burnout as Health Architects, a series in which we talk about different ways that physicians can approach their clinical work to make it more rewarding and fulfilling. This is Venkatesh Ramnath. Today is episode 9. How does the scientific attitude evolve during training years? How do we evolve with it? For your information, if you prefer reading, I would invite you to take a look at the written post, which also has embedded links for references that are cited. In our last episode, we talked about how medical school shapes our mindset and identity as doctors. But here's a catch. Medical school alone isn't enough. No one walks out of their white coat ceremony ready to practice independently. That's where real-world training comes in. In law, finance, and business, on-the-job training is the norm. Medicine is no different. Some argue that residency should be shorter, and hey, yeah, they may have a point. But let's be real. Training isn't just about checking off requirements. It's about bridging the gap between theory and practice. This is when the scientific attitude truly matters. The field of cognitive science helps us understand why both medical school and residency are crucial to becoming a confident, competent doctor. John Vervaeke, a professor of cognitive psychology at the University of Toronto, describes 4 kinds of knowledge. Number 1, propositional knowledge, the facts. This is the textbook stuff. Number 2, perspectival knowledge. This is the ability to see through different lenses, learning from mentors and colleagues who approach the same problem in different ways. Number 3, procedural knowledge. This is the skills, the hands-on work, like placing a central line or managing a crashing patient. Number 4, participatory knowledge. This is the lived experience, the feeling of being a physician in the moment, making the calls that matter. Now, medical school gives us a solid foundation of propositional knowledge, tons of facts, empirical truths, and mechanisms of disease. But residency and fellowship? Well, that's where the real-life learning curve kicks in. That's where you get thrown into the deep end, developing perspectival, procedural, and participatory knowledge. For example, I still remember how my perspective changed every time I had a new attending on service. One week, I was told to order empiric steroids for a suspected interstitial lung disease. The next week, a different attending insisted on waiting for biopsy results first. Similarly, nephrologists, surgeons, and other consultants gave recommendations that sometimes contradicted one another. Even my peers, residents just like me, had different approaches to the same clinical problem. What's more, at the time, we weren't even aware of our own cognitive biases in medicine, a topic that got popularized with Malcolm Gladwell's book Blink, which hit bookshelves in 2005. Since then, we've become increasingly aware that not only do we have different perspectives from each other, we also have different perspectives within ourselves. We'll talk about cognitive biases more in a later post. Now, what about procedural learning? Well, that was like drinking from a fire hose too. I had to figure out how rounds on the oncology floor different from the cardiac step-down unit, like what parts of the exam would be scrutinized while others went ignored. For example, I remember when a fellow resident was chided by the attending cardiologist after spending more time on an abnormal lymph node he found in the neck than the primary arrhythmia. Ironically, the new diagnosis of lymphoma only partially changed the attending's opinion. Procedural learning also included how to optimally position a patient for procedures like a central venous catheter placement in the internal jugular vein of the neck, or how to document notes correctly, because a missing detail could result in an overlooked treatment, or worse, land me in a legal quagmire. Despite all these procedural pressures, however, by the end of training, we became operational powerhouses, able to multitask like few can, fielding nurses' pages, new admissions from the ED, calls from pharmacists, crashing blood pressures, patients' complaints, and myriad other issues, often simultaneously. Finally, there was participatory knowledge, the feeling of being a physician. Participatory knowledge was the knowledge of how propositional, perspectival, and procedural knowledge all intersected and became internalized in our bones by sheer repetition. Seeing more than 20 patients a day and covering up to 100 at night, week after week, month after month, from mild headaches to florid bacterial meningitis, minor cuts to life-threatening hemorrhages, superficial skin cancers to invasive metastatic disease, simple colds to devastating sepsis, and mild anxiety to crippling catatonia. My knowledge of how to critically think about disease and make crucial decisions became a new way of being in the world and moving within that world. Without training years, being a physician is just a technical exercise, but with them, it becomes a vocation. Okay, well, that's what we got in training. But let's now talk about what we didn't get in training: a healthy relationship with the physical and mental demands of the job. Jimmy Connors, an icon of American tennis, allegedly once said, "The first 90% of tennis is physical. The other 90% is mental." Honestly, the same could be said about medicine. First, the physical part. No one prepared me for the physical toll of residency. Every morning, I would spend hours power walking what felt like miles to the hospital, pre-rounding on my patients before rushing to morning report by 8 a.m. During my 27 to 30-hour shifts taking place every fourth night, I flung myself into every corner of the hospital, drawing blood, examining patients, reviewing x-rays with the radiologist in the radiology reading room, and even lugging around a 30-pound yellow defibrillator machine when I was on the ICU service. Others actually put it on a rack with wheels and pull it around like carry-on luggage, but for me this was impractical when I was trying to run to a code blue in which delay by minutes could be fatal. Even though I was in my 20s still, I could feel the strain on my body. During my ward and ICU rotations, I still remember constantly fighting off the irresistible urge to sit down as morning rounds limped along after a long night on call. Now that was a physical toll, but there was also a mental one. As an intern, seeing tasks through was as mentally straightforward as walking through a booby-trapped obstacle course on ice. At any moment, I had to be prepared that things could suddenly be derailed and then take more time to get back on track. Soon, I realized the necessity of being a paranoid micromanager. Take, for example, a simple lab test order. What was tough wasn't the ordering of the test itself in the electronic medical record, the EMR. It was entering the order in the EMR, confirming it appeared in the order task list and that the label was printed, checking that the nurse received it, tracking down the phlebotomist down the hall to confirm they got the call, or drawing the blood myself, which often happened, verifying with them that the blood was drawn, ensuring that it made it to the lab, or actually walking the specimen over myself, confirming that the lab team processed it, getting the result, documenting the note, and then doing it all over again for another patient. Each step, done for each patient, required countless phone calls, trips in and out of patients' rooms, and interfacing with staff constantly. The corroborative process was unending. To survive, you had to be obsessional. That is, if you weren't already. While I did more supervising than direct labor in the later years of residency, I still had to keep on top of these processes and be ready to jump in at a moment's notice whenever an intern fell short. Meanwhile, with multiple interns buzzing around the hospital under my watch, my constant vigilance over all the tasks happening in parallel was exhausting, just in a different way from before. I started each day with a list that I checked off as I went, but the list kept growing. I was always caught in the crossfire of new information from nurses, consultants I passed in the hallway, or new test results that kept popping up in the EMR. But there was more. As a resident, I was now expected to move beyond just being a clerk and devise cogent treatment plans, often on the run. Despite the heightened responsibility, there was no sanctuary of reflective time to cogitate over this diagnosis or that treatment plan. Meanwhile, this was a high-stakes game, which added to my paranoia, not just about making a potential error, but that someone else might discover one that I made. This led to a predictable consequence, a panicked fear of making mistakes. One night, I got two patients confused and accidentally ordered morphine for the wrong one, a woman in respiratory distress from a pulmonary embolism rather than the man with end-stage cancer in his bones. The moment I realized my mistake, I sprinted to her bedside, yelling for naloxone to reverse it. She was okay, but actually I wasn't, at least not for days. No one was talking about the mental aspects of the job, that is, the other 90%. No one talked about how to handle the kind of stresses we faced daily. We were just supposed to push through while our superiors seduced us with claims that things would eventually get better. Well, after training ended, they didn't. The physical and mental demands didn't magically disappear overnight when we became attending physicians. Yet we still haven't adapted. We still don't place enough attention on general physical fitness. One survey found that less than a quarter of physicians exercise regularly, and a third don't exercise at all, indicating that our commitment to physical fitness is still an issue. Nevertheless, the physical demands of the job continue. Doctors on average walk 5,000 steps a day at work, not including the hours spent standing during rounds, procedures, or surgeries. Worse still, we face this demand with lower supply, so we don't sleep enough and we eat poorly. And both of these have been linked directly to burnout. Here's the reality. During residency, all of these bad habits became normalized as part of our routines, as part of participatory knowledge, our lived experience of what it means to be a physician. The survival behaviors we developed then are still alive and well within us now. Our training years conditioned us for burnout. As a result, our sense of well-being is completely upside down. So how do we change this? Well, first ask yourself, would Novak Djokovic, LeBron James, or any other serious professional athlete neglect both the physical and mental demands of their work? Of course not. Why should medicine be any different? Maybe we should think of ourselves the way they do. Here's the good news. We can change. We can evolve. I was one person when I started medical school. I was a different person in residency, and I'm still a different one now. The only constant is change and how I want to face tomorrow. This is exactly why I created the Health Architect model, to make a new oath to a sustainable practice of medicine today. We can't keep running at a sprint when we're actually in a marathon. We have to reorient, rethink, and strategically prepare ourselves both physically and mentally. So how do we move forward as health architects? By making newer and better choices. For example, I chose to reaffirm my scientific attitude. That's my anchor. It's what connects me to my peers, mentors, nurses, and patients. Letting go of that would mean letting go of a core part of who I am. But I also had to nourish it by actively promoting it, because left unattended, even the strongest foundations will crumble. Now, I found that restoring a healthier, more fulfilling balance of physical and mental demands in the practice of medicine could move from there. My focus wasn't about how long medical school should be or whether residency should have been shorter. Those things still built the foundation. But for me, the real transformation came when I extended that foundation creatively. I recognized the lopsidedness of my physical and mental preparedness for the vocation of being a physician. I committed to generating a new participatory knowledge with things that medical school never taught me. Physically, I committed to sleeping earlier, minimizing night shifts, working out regularly, and eating healthier. Mentally, I learned communication skills, financial literacy, team-based decision-making, and other skills. And to my surprise, well, that's when medicine suddenly became exciting again, because the world of medicine isn't static, and neither was I. As I adapted to a new world around me, the new world adapted back, and the practice of medicine became what cognitive scientists call a transjective experience. As part of this give and take, my identity shifted. Now as a health architect, I redefine myself actively and creatively in ways that allow me to thrive within, and sometimes despite, the system. Take-home point. Medical training is more than just acquiring knowledge. It's about transforming into a physician. While medical school provides foundational facts, training years offer real-world experience that develops critical skills, perspective taking, hands-on procedures, and the confidence to make high-stakes decisions. However, training also normalizes unhealthy habits leading to burnout. To sustain a lifelong and fulfilling career in medicine, we must rethink how we prepare both mentally and physically. The Health Architect model offers a new approach, one that empowers physicians to evolve, adapt, and thrive in an ever-changing healthcare system. Okay, I hope you enjoyed this post, and if you did, please click like. In the upcoming episode, we'll talk about how to expand our knowledge bases and our scientific attitude after the training years have finished. I'll follow that up with a discussion about AI and ChatGPT. See you soon.